I'll give a brief introduction of myself. I am Dr. Jerome Wesley Vivian. I work as a scientist B at ICMR National Institute of Epidemiology. So, with these words, I will start my presentation. Japanese encephalitis is a vector-borne zoonotic viral disease. It is a viral disease because it is caused by a Japanese encephalitis virus, which belongs to the flavivirus group. And it is zoonotic because the virus is transmitted from the humans, and it is vector because the virus is transmitted through mosquitoes, and mosquitoes act as a vector between the animals and the humans. And it is spread by the bite of the infected mosquitoes, especially of Culex species. Most of the cases of Japanese encephalitis occur only in children, and this disease affects the brain and central nervous system. So, in the northern part, this disease is famously called Dimaki Bukar or Chamki Bukar. The disease gained predominance because of its high case fatality. It is 20% to 30%. If there are 100 cases of JE, then there is a high probability that 20 to 30% will die. And even among the people who survive, 30 to 50% can suffer from either mental disability or physical disability, or both mental and physical disability. Next, on the Japanese encephalitis virus. It is a single-stranded RNA flavivirus. It belongs to the genus Flavivirus and the family Flaviviridae. It is spherical in shape. And if you look at the cross-sectional structure, if you get a cross-sectional cut and see the structure, we have an outer envelope and an inner nucleocapsid. The outer envelope has a lipid membrane and the glycoprotein, and the inner nucleocapsid, inner to which we have the viral genome. Till date, we have only one serotype, but there are 5 genotypes that have been identified: G1, G2, G3, G4, and G5. And a very special feature of Japanese encephalitis virus is that it is very antigenically related to West Nile, yellow, and in Indian context, the more importantly, dengue virus. The dengue virus also belongs to the same flavivirus group, and both dengue virus and Japanese encephalitis virus share this lot of the structures. They share a similar structure, the both dengue and the Japanese encephalitis virus. If you look at the origin of the JE virus and the strain distribution, the first case of JE was documented in 1871 in Japan. So that's why the name it is called Japanese encephalitis. Encephalitis because it is affecting the brain. Encephal means brain or head, so it is affecting the brain. So it is called Japanese encephalitis. However, the first strain isolated from the brain case was in 1935. That's where we knew that it was due to JE virus. Even though the first case was documented in 71, the case that happened in around 1933, where we had the Nayakama strain, could be attributed to JE virus. However, we had JE outbreaks in Korea, in China, in Philippines, and in India between 1930 and 1955. And till date, G3 is the most commonly circulating genotype among the endemic countries. Next, on the burden of Japanese encephalitis, you can look at the picture. It's very clear that the virus is endemic or present only in Southeast Asian countries and in some of the Western Pacific countries. Southeast Asian countries, mainly India, China, Korea, Japan, Indonesia, Philippines, and to an extent in Indonesia and Myanmar. And most of the cases are reported from China and India. That is, 86% of the cases are reported from China and India. And every year, globally, we have around 68,000 of JE cases reported. This translates into an incidence rate of 1.8 per 1 lakh population. For every 1 lakh population in this region, we have 2 new cases of JE reported every year. And there are around 13, the range 13,600 and 20,400 deaths occur due to JE in the countries, in these countries. We all know these are all very conservative figures because in many countries, lab diagnosis of JE don't happen, and many with JE even don't reach the die before even reaching the health facility. So this is a very conservative figure, and there is an economic loss due to the disease, and it has been calculated around 7,09,000 disability adjusted life years lost due to the disease. As I told you before, there is huge mortality and also disability. So there is a huge economic cost that is lost due to the disease because of premature death and disability that happens in the children. So in total, there are 25 Asian countries where the 60% of the whole population, the global population lives, are at the risk of exposure to Japanese encephalitis. Tracing the history of Japanese encephalitis in India, the first evidence of JE viral activity was recorded during a Sero survey in 1952. However, the first human case due to JE was documented in Christian Medical College, Vellore in Tamil Nadu. And after 20 years, in 1973 and 1976, Bankura and Buduan districts of West Bengal experienced JE outbreak. JE can sporadically present throughout the year in endemic areas and can present as an outbreak also. And they present primarily as an outbreak. And considering the case load, in 1978, the National Malaria Eradication Program was was given an additional charge to monitor JE in the country. And in 2003, we had a separate vertical program for JE, National Program for Prevention and Control of JE. And in 2005, the Gorakhpur region, the eastern part of Uttar Pradesh, experienced a very severe outbreak in 2005, which made to introduce the JE vaccination in the country. So JE was primarily a disease of rural areas, but in 2011, first time cases were reported from Delhi. Even though JE cases were reported from Assam, only in 2013 we had cases from Tripura and Arunachal Pradesh. That is, the disease was spreading from Assam to other parts of the northeast region. If you look at the number of cases that has been reported to National Vector-Borne Control Disease Program, if you look at in Odisha, the number of AES cases and JE cases have increased since 2016. In 2016 and between 2016 and 2019, on an average, there were around 1,500 cases, AES cases reported, and 150 JE cases were reported. Probably in 2021, we have a very steep decline that can be attributed to the COVID pandemic, the ongoing COVID pandemic. The similar situation, with similar trend we see in India, in India, the overall status also. There has been a decline in cases in 2020 and 2021, but this trend is the same in other JE endemic states. If we look at the incidence of JE in India, you get a very clear picture that JE is prevalent or happens only in northeastern part, eastern part, southern part. The western, central, and northern part, except Uttar Pradesh, are spared. So the picture, this slide clearly depicts the distribution of JE cases in the country. More number of JE cases are reported from northeastern part, followed by the eastern part, than the southern part. Based on this, the program, the National Vector-Borne Disease Control Program for AES-JE has classified 171 districts as endemic districts, and there are high priority districts. There are 60 high priority districts of 5 states, namely in Uttar Pradesh, Bihar, Assam, West Bengal, and Tamil Nadu. These have been classified as high priority case because of high incidence of JE cases in the recent past. However, these are the numbers from 2014. The number of endemic districts would have increased by now. On epidemiology of JE cases, traditionally JE is considered as childhood disease. Mostly children get affected by this disease. If you look at the incidence by age group, there are 5 to 6 cases that can happen per 1 lakh population in children less than in pediatric age group. However, the incidence is less than 1 in age group above 15 years. So this is mostly the children are affected because of JE. Once you are infected with Japanese encephalitis virus, then it confers you with lifelong immunity. So that's one of the reason in the endemic areas that adults don't get the disease, whereas the child who are naive, who are susceptible, get the disease. However, the disease can occur at all ages. Even in adults, the disease can occur. It can occur in areas where there has been no pre-existing immunity. Whenever there is a migration of the virus across the borders, when there are no pre-existing immunity in the community, then adults also can get affected. And whenever there is a high vaccination in younger age groups, below 5, then there is a shift in age of infection above 5. If we see the sex distribution of the cases, male and female more or less are equally or prone for the disease. As I told you before, predominantly this Japanese encephalitis is a disease of rural areas and peri-urban settings. However, some cases are still noted in, are happen in urban areas. If you look at the JE outbreaks seasonal variation, we have witnessed JE outbreaks in Uttar Pradesh, Maharashtra, and West Bengal, primarily after the monsoon because of the high vector density. And there are sporadic cases that occur throughout the year in endemic areas. But however, JE outbreaks predominantly occur post-monsoon, during monsoon or post-monsoon because of the high vector density. And the outbreaks are determined by the availability of the breeding sites, temperature, and the cropping pattern. That the Culex mosquitoes have a predilection for or breed in can breed in the areas where rice and paddy are cultivated, because you have to have the water has to stand in this field for the rice or the paddy to grow. So wherever there are rice cultivation, then those are prone for high risk for JE outbreaks. I would like to spend some time in this slide. Very interesting transmission dynamics that we have for Japanese encephalitis virus. It's primarily an enzoonotic cycle. That is, the virus transmission is between the mosquitoes, the birds, the wild birds, the water birds, and the pigs. And if you look at the picture, there is a cycle. Yeah, we have the bottommost mosquito, then we have a bird, again a mosquito, again a pig. So we'll start with the mosquito. The mosquito, then the infected mosquito, especially the Culex species, go on to infect the water birds. Water birds are natural reservoirs. The virus can very normally grow in these water birds. And mosquitoes feeding on these birds are again infected with the JEV virus. And these mosquitoes they have a feeding habit, especially on cattle and pigs. So when they feed on the pigs, then the virus gets amplified. So the pig acts as an amplifier host. So the replication of virus is amplified, and this is how the virus is maintained between the birds and the pigs and the mosquitoes. What happens is the the human habitat, which is near to the areas where the mosquitoes breed or where the poultries or piggeries are found, that's where human get infected. And the human is basically a dead end host. The human to human transmission is not possible. So once the mosquito bites the human, he's infected with the virus. But like in malaria, the mosquitoes cannot again feed on humans to pick up the virus again and to transmit to others. So very interesting cycle. And also in cattle, it does not cause disease, because once the cattle are infected with JEV, they develop sufficient antibodies such that they also act as a dead end host. The transmission is not propagated further. So why pigs are amplifying host? So they have a natural infection with this JEV virus, and this Pulex species have a predilection, or they have a favoritism to feed on pigs. They like feeding on swine blood, and the viremia remains very high enough to infect mosquitoes for up to 4 days. If you remember, so the feeding preference for vector mosquitoes to feed on swine is very high. As I have told you before, cattle do not circulate the virus because they develop antibodies. Hence, they do not act as a natural host for the virus. And these water birds, they can serve as a reservoir, or they can serve as a natural host. The virus can normally multiply in these natural hosts and do not cause any disease in these birds. So over 90 bird species are known to be reservoir host to JEV. And among them, the most highly susceptible to JEV infection are the water birds, just as shown in the figure. You might have seen this a lot of water birds. In Tamil, we call them as Nara, Kokku. I don't know how you call it in Korea. So these are all called pond herons, cattle egrets, poultry birds, ducks, and sparrows. These are all the primary reservoirs, and they contribute to transmission. And migratory birds may be involved in the transfer of virus from one region to another region. Vector. The major vector in India are the Culex species, and among the Culex species, the Culex tritaranicus and the Culex vishnuvi and Culex pseudo-vishnuvi are the major vectors that are in India, and the Culex tritaranicus is the major vector that transmit the disease between the animals and humans in India. And if you see the vectors, these breed in rice fields. That is, wherever there are clear water, they can breed on the clear water, such as rice fields, swamps with aquatic vegetation, both hydatids and lilies, and ponds, clear ponds, ground pool, and irrigation channels. These are all their breeding habitats, and they can rest outdoor in vegetation and in other shaded places. So when they rest outdoor, that is where the man is exposed and they get the infection when the man goes to the field or when the child goes to the field for playing. So what happens when an infected mosquito bites a human being? What happens? So most of the JE infections are asymptomatic. If when a mosquito bites a human being, then mostly he will not develop any symptoms. If at all he will develop a mild prodromal symptoms such as feverish or warmth or a headache with slight myalgia. But only one severe disease case per 252,000 JEV infections develop. You might all know only 1 or 2 cases will be reported from a village. Even though village will have on an average 1,000 population, we will have only 1 or 2 cases that are reported from village. That is primarily because these JEV infections are asymptomatic. But as I have told you earlier, that this can cause very high case fatality. Those who develop severe disease, around 20 to 30% die. And among people who survive, 30% can develop, 30 to 50% can develop physical or or mental disability. Physical disability in the sense the child will have difficulty in walking, doing her day-to-day activities, and someone should be taking care of the child for the entire time period. And mental disability, the child will be having a slurred speech. He will have a small disorientation. His milestone for age will regress. He will go back to a child age. So those are all the mental disabilities and physical disabilities that happen post the diseases. Primarily, younger children have a great risk of acquiring the disease. This is because the JE infection can offer a lifelong immunity. Most of the adults would have been already exposed to JEV. Only the naive susceptible population, the birth cohort, the children, will be susceptible for developing JEV. Clinical presentation. This has a very clear-cut clinical presentation. There is a prodromal stage and there is a encephalitis stage. In the prodromal stage, typical complaint is fever, very high-grade fever, along with chills and rigors, severe headache, nausea, feeling, and vomiting. This high-grade fever then translates into what is called change in mental status or altered sensory. The child becomes confused, disoriented, goes into coma or inability to talk. The typical clinical feature, the mother says the child was very active. He was playing, he was feeding. There was absolutely no problem. Then suddenly he developed fever for 2 or 3 days. Then after fever, he became confused. He lost orientation to the place where he lives. He lost orientation to the time. He is confused. He refuses feeds. He do not take food. So these are the typical features that the mother says. जैसे हिंदी में वो बताते हैं कि बच्चा ठीक ठाक था, एकदम बुखार आया, बुखार चढ़ा, फिर उनको एकदम बच्चा फिर बेहोश हो गया, बोल नहीं पा रहा है या खेल नहीं पा रहा है या खाना पीना सब बंद हो गया. यही वो typical. This is the typical clinical presentation with JE. And this altered sensorium can present with or without convulsions. Diagnosis of Japanese encephalitis. So we can diagnose JE into three categories. One is the suspected case, another is the laboratory confirmed case, third is the probable case. The suspected case is one which has an acute onset of fever, not more than 5 to 7 days of duration, with change in mental status. As I have told you, that there will be change in altered sensorium. The child will look confused, he will be disoriented, he will not know whom he is talking to, he will not know where he is, he will not know about the time, and he can present with or without seizures. And other clinical findings can be irritability, somnolence, or abnormal behavior. So this we call as acute encephalitis syndrome. This picture we call it as acute encephalitis syndrome. Whenever there is an acute encephalitis syndrome, then the immediate thing that comes into our mind is it can be a suspected Japanese encephalitis case. So you cannot miss a JE case. So it will have a very typical presentation. Fever, a prodromal stage, followed by an encephalitis stage. Encephalitis stage having altered sensorium, the child going into unconscious or coma. And all this happens in a very short span of time in a very healthy child. So we will call it as a lab confirmed case when the suspected case, when a case with all these findings have any one of the following laboratory confirmed investigation. That is presence of IgM antibody specific to Japanese encephalitis virus in serum and or in CSF, cerebrospinal fluid. Or if we can demonstrate fourfold difference in IgG antibody titer in a paired sera that is taken in a different points of time. or if we can isolate virus from brain tissue, or if we can detect antigen by immunofluorescence, or if we can detect by nucleic acid by PCR like we do for COVID, then we can call it as laboratory confirmed. But in India, the most commonly used laboratory test is the IgM ELISA capture, the first one that I have highlighted in bold. That is what is used most commonly across laboratories to confirm JE case. So they collect blood from the child, they separate serum or the CSF, and they perform the ELISA test, and they look for IgM specific to Japanese encephalitis virus. So if a person has fever with altered sensorium, and in his blood or CSF, if we confirm IgM specific to JE, then it is labeled as a laboratory confirmed case. Then there is another diagnosis where we classify is the probable case. The suspected case in close geographic or temporal relation to a laboratory confirmed case of JE in an outbreak. So if there is an outbreak, if there are a lot of AES-like cases or JE-like cases in the same village or in an adjoining village or from the same block or from the border areas of the affected block, then we can label them as probable cases. But they have to have the clinical features as defined in the suspected case definition. Clinical management, sadly, we do not have a very specific treatment for JE. Whatever treatment we give is supportive to relieve symptoms, to save the patient from death. That is, we make sure ABC, management of airways, that is, airways should be clear for breathing, and we manage circulation to avoid septic shock. If there are convulsions, then we use anti-epileptic drugs to control convulsions, and for temperature, we give analgesics. And again, it is the fluid and electrolyte balance that we do. So sadly, there is no specific management for Japanese encephalitis, but however, we can give supportive treatment and we can save the patient if we can pick up the case very, very early. So what to do at a community level? One, we have to look for JE cases. We have to tune our mind to look for JE cases. Anyone who says that the child, especially in children, who says they had fever 3 or 4 days or 1 or 2 days, then followed by this altered sensorium or change in mental status. That if they say that, then we have to definitely suspect AES or especially JE, and we have to look for the danger signs. So जैसे बच्चा बेहोश हो गया, या the child becomes unconscious or starts throwing fits, then he has to be definitely referred to a first referral unit where the patient will be managed, will be given supportive therapy. So at a community level, what we expect is identification of the case, identification of the danger signs, and prompt referral to the first referral unit or refer to the tertiary care hospital. So I would like to thank Dr. Rupa Kumari, Technical Officer WHO, and Dr. Kamran Zaman, Scientist E, who has, I have used their slides extensively in my presentation. Thank you.